بس ان شاء الله. السلام عليكم. المحاضرتين اللي قبل كنا نحكي على we are talking about the multiple sclerosis and its variant. We reached the differential diagnosis. We talk about the inflammatory cause of the differential diagnosis. Today we talk about the vascular, infective, and metabolic and toxin, and a few words about the immunoplastic differential diagnosis of multiple sclerosis. The vascular cause of the vascular causes could be divided into the age-related small vessels disease or reversible cerebral vasoconstrictive syndrome, Moya disease, Cardicel, and migraine and Sossack syndrome. The first age-related, it is a deep cerebral white matter disease, usually affected the middle age, more than 50 to 60 years. Cortical gray matter, brainstem has, because the cortical gray matter and the brainstem have a robust collateral blood supply, thus minimize the risk of ischemia. They are usually asymptomatic. Lacunar infection, one of the vascular disease, which is between the 5 to 15 millimeter in diameter, occurring within the basal ganglia and typically in upper two-thirds of the putamen. MRI in acute phase, usually there's low signal intensity in T1, high signal intensity in T2, and flare. The restricted diffusion, usually in acute phase, there will be restricted diffusion, which is not visible in the other T1 and T2 sequence. Contrast enhancement may be seen in the early subacute. In the chronic state, they will be isointense to the CSF in all sequence. This is the flare serial of the flare image, axial MRI, which is seen marked sign of the subcortical atherosclerotic encephalopathy. In the 2 years later, show definitive progressive of the small vessel disease, even more pronounced in the subcortical atherosclerotic encephalopathy with confluence of the white matter lesions sparing the U fibers. This is also another case of small vessel disease. There's apparent typical small vessel disease within the white matter hyperintensity. In the series susceptible weighted image, there will be some multiple subcortical microhemorrhage within the most constituent of the amyloid angiopathy. A prominent perivascular space is another differential diagnosis. It's called virtual Robin space, which is mimic deep white matter or lacunar infection, symptoms affecting the symptoms vary and the lower basal ganglia at the level of the anterior commissure, where the lenticulostriate artery enters the brain parenchyma. It is usually 1 to 2 millimeter in diameter, but can be considered as a large on axial. Maybe large on axial image. This smoothly demarcated fluid-filled cyst, typically less than 5 millimeter in diameter, showing the same attenuation intensity of the CSF, and it's often found in the basal ganglia and the midbrain. This is T2 and flare. This is the typical CSF signal in T2 and the flare. Some variant, there will be radial distribution of the virtual Roman space, and sometimes in the inferior infratentorial in the midbrain should not be mistaken with the lacunar or should not be mistaken with the multiple sclerosis. Again, this is a diffuse high convexity MRI showing the grade 3 virtual Robin space with the sand-like appearance. It's multiple small hyperintense T2 lesion with low signal in the flare. This is which is the typical for the Robin. The feature is including the round oval shape, well-defined, smooth marginated, located along the pathway of the penetrating artery, isointense relative to the CSF, with no enhancement in contrast enhancement. This is an important, it's not enhanced after the IV contrast. Reversible cerebral vasoconstrictive syndrome. It may occur spontaneously, but it's usually associated with a precipitating factor, such as use of the vasoactive substance, ergotamine derivatives, amphetamine, nasal decongestant, contraceptive, late pregnancy and perpedium and catecholamine may produce tumor, may have a role in this disease. Features are suggestive in the reverse vascular vasoconstrictive syndrome, is acute thunderclap headache with a normal CSF analysis. MRI normal, usually normal, unless it's complicated by the one of the following: either intracerebral or cortical or subcortical hemorrhage, either cerebral infarction or posterior reversible encephalopathy syndrome. Cerebral angiography, which is usually seen at the multifocal cerebral artery vasoconstriction with no evidence of aneurysmal or subarachnoid hemorrhage. By definition, substantially or completely reversed within the approximately three months. This is MRI, in which normal caliber in internal middle cerebral and anterior cerebral artery and vertebral arteries, while in the other sequence there will be in flared image subtle high signal in the occipital, parieto-occipital region, which is representing the parenchymal edema, with an inflared, which will be enlargement of the parieto-occipital area with restricted diffusion, which is representing the edema of the brain parenchyma. Another disease, myotonia disease, which is progressive occlusive condition of the supracrinoid terminal part of the internal carotid artery, which is idiopathic or familiar condition. It's bimodal in distribution. The first peak in the 4th years of the age. The second peak is 30 to 40. Its characteristic image, including marked narrowing or occlusion of the terminal internal carotid artery, usually bilateral, but maybe asymmetric and occasionally unilateral, with the formation of the diffuse extensive network of tiny collateral results throughout the deep gray matter structure. On angiography, the enhancement of these collaterals usually resulting in the dense flush of the contrast, giving rise of the puff of smoke appearance. This is what I said. This is the T2 axial with this is what's called subtle signal void in the middle cerebral internal carotid artery. This is which was called a flow void, by an incomplete flow void. Usually, this will be a complete flow void in this image, but it's not complete, with a multiple area of the small flow void. Incomplete flow void through the bilateral basal ganglia corresponding to the myotonia collaterals. This is collaterals corresponding to the collaterals. This is angiography. It shows the minor narrowing of the supracranial part of the internal carotid artery, with multiple collaterals appear under in this angiography. Cadasal disease, it's a cerebral autosomal dominant arteriopathy with a subcortical infarct and leukoencephalopathy. It is an inheritable condition related to the notch of the NOS3 mutation on the chromosome 90, presented with the ischemic change and often in the middle age. Subcortical anterior temporal and medial frontal lesion is relatively specific for the condition. This is different from the difference in the anatomic distribution of the white matter involvement, in contrast to the routine small vessel ischemia change. It's felt that the cadasal will affect the slightly larger caliber leptomeningeal vessels. Sorry. This is what we say the cadasal disease. This is the high signal intensity in the anterior temporal, with the middle frontal, with the insular subcortical cortical insular cortex, which is this area specific for the cadastral disease. Mosaic syndrome, it is known as the retinocochlear-cerebral vasculoplasty, which is a raised syndrome. Small infraction occur in the cochlear, retina, and the brain parenchyma, affecting young to middle-aged women. It's characterized by the triad acute, subacute encephalopathy, bilateral sensorineural hearing loss with branch retinal arterial occlusion. The lesion is usually appear in the snowball shape in the callosal lesion, callosal thinning in the late stage, strength of the appearance of due to the involvement of the posterior internal capsule. There will be silent infarction with micro bleed and may appear. So I say this is the multiple snowball appearance in the corpus callosal with a black hole in the genome, which is presented in the case with multiple lesion in this corpus callosum, and in diffusion which image there is what we say the sticking of the appearance in the posterior limb of the internal capsule. This is the cadastral disease with Sussex disease, which is in cadastral disease usually appear in the anterior temporal with the subcortical insular cortex, while in the Sussex disease usually occur in as a signal intensity in the corpus callosum. Migraine is another differential diagnosis of the vascular differential diagnosis in the multiple sclerosis. Common primary headache disorders can be presented variably, consistent with disabling headache accompanied by the aura in 1/3 of the patient. The etiology remain controversial throughout the change in several vessels. Reactivity are involved. MRI usually is normal. In hemiplegic migraine, venous dilatation can be seen on the CV minimal intensity projection. Image the contralateral and the hemisphere, although there will be typical. Change in the cerebral perfusion will be seen in the relative blood, cerebral blood perfusion. MRI may demonstrate to hyperintensity in the white matter of the centrum semi-ovale, and no disliminate to the small vessels, deep white matter, ischemic change. These are distinguished predominantly in the history. There will be on history of the patient. It will help in this discrimination between the MS and the migraine. On recent Tesla work suggests that there is an increased T2 signal on the cortex overlying the white matter abnormality as well as in the brainstem. This is a case of the migraine, which is showed in the coronal flares, so subcortical some signal change with contrast show the laminar enhancement in the cortical white matter junction. In the follow-up, show the complete resolution of the disease. This is the summary of what we are saying in the distribution of the vascular and multiple sclerosis. The difference between MS and vascular lesion in the corpus callosum usually uncommon in the vascular, and the U fiber is also uncommon in the vascular course, while in multiple sclerosis are common. The cortical region and the infarction will be seen in the vascular, while sometimes there's uncommon in the multiple sclerosis. There will be if there be a cortical involvement. Basal sulci are typical for the vascular, while uncommon in the multiple sclerosis. Intratemporal, temporal, and parietal and spinal cord are uncommon for the vascular, while it is common and maybe typical for the multiple sclerosis. Gadolinium enhancement, there will be no gadolinium enhancement in the vascular lesion, while there will be variable enhancement in the multiple sclerosis. Usually the vascular are asymmetric, while in multiple sclerosis mostly are maybe symmetrical and diffuse. The third group of the differential diagnosis is infective. This is infective cause, progressive myeloleucoencephalopathy, and herpes encephalitis, subacute sclerotic encephalitis, HIV, Whipple, and Lyme disease. in progressive multifocal leukoencephalopathy, the causative organs usually JC viruses. It is deployed 4 to 7% of AIDS patient, and the virus infected. This virus will infect and destroy the oligodendrocyte, resulting in the multifocal demyelination. MRI, most common site of the involvement are classical for PML is the posterior centrum cerebral valley. Typically, the disease begins to the posterior subcortical lobar white matter. The U fiber are always involved. This fiber from the pattern, this differ from the pattern of the HIV encephalopathy. It is usually a differentiating feature. The cortical gray matter is spread. The image is advanced in stage, demonstrating the white matter region with high T2 signal intensity. أستاذ صوتي مسموع؟
مسموع.
أستاذ. The intensity expands over the time and become confluent. The thalamus, basal ganglia, corpus callosum, and the infratemporal structure may also be affected. Involvement of the brainstem and the cerebellum is also common. Contrast enhancement is almost always absent. There is no mass effect, it's very rare mass effect. Unlike the classical PML, the enhancement is more likely to occur in PML treated with the potent immunosuppressive or monoclonal antibody. If it is treated, there will be enhancement, but without treatment of the PML, there will be no enhancement. This is the case of PML, which is 33 years old woman. The hyperintensity of the posterior white matter of the occipital lobe are the typical finding. This is with the in contrast to with no the U fiber are also involved, and the infratentorial cerebellum and peduncle are also affected. The infratentorial also is involved in this disease. Herpes encephalitis is the most common fatal encephalitis. Children and adults could be in the children and adult. Herpes simplex type 1, which is oral herpes, mostly in the adult, while the neonatal one is type 2, which is the genital herpes, are caused by the in children is present. Herpes simplex type 1 are particularly predilection of the limbic system with a localization of infection to the temporal lobe, insular cortex, subfrontal area, and the singular gyrus. MRI is a high signal T2 involving the cortex, the subcortical structure, presenting as encephalitis and variable contrast enhancement. Initial herpes simplex are usually unilateral, however, the sequential bilateral involvement of the highly suggestive of the disease. Fulminating necrotizing meningoencephalitis associated with the edema, necrosis, hemorrhage, eventually encephalomalacia. Hemorrhage with an area of involvement of the parenchyma is a supportive diagnosis of the disease. High serial image of the T2 and flare with contrast, T2 contrast, show the left temporal lobe presented inflammatory inflammation of the brain with typical involvement of the limbic system. The temporal lobe with involvement bilateral also in the contralateral temporal lobe will involve, and with contrast there will be gyriform enhancement of the area with cortico-subcortical gyral enhancement representing the edema and the enhancement of the affected area. Subacute sclerotic panencephalitis is also a rare chronic reactive, slowly progressive infection caused by the measles virus. Children between 5 to 12 years are who have had the measles before the 3 years of the age are typically affected. MRI demonstrates patchy area of the periventricular demyelination as well as at the basal ganglia. The disease course is variable and may be rapidly progressive and protracted. HIV, it is a symmetrical periventricular and deep white matter T2 hyperintensity relative to sparing to the subcortical white matter, posterior fossa structure confluent or are patchy. Usually there's no mass effect, no enhancement. On spectroscopy, show decrease in aspartate and increase choline peak and change in the glutamine level. This is the HIV, which is show that symmetrical confluence hyperintense signal was corresponding to the large area of the high signal intensity with any evidence of mass effect. Whipple, it's a rare infection, multisystemic disease disorder caused by the bacteria Whipple. It's a 10-20% of the Whipple disease. A patient develop neurological symptoms while the rest of the cases remain asymptomatic. On MRI, T2 hyperintense mild enhanced lesion and the cortical tract diffusion demonstrate the area do not demonstrate any restrictive diffusion. This is what I say. This is the small lesion in the midbrain, which is not in show some sort of enhancement. And in the infratemporal, this is the non-constant state demonstrating the bilateral symmetrical T2 signal intensity without any mass effect. But this is the abnormal high signal intensity in the midbrain without any mass effect with involvement of the cortical spinal and brainstem area. Lyme disease also it's known as borreliosis, as a condition caused by the Borrelia burgdorferi, which is an infected being via the exodyte tick. A radiological feature, intracranial MRI findings, patient with Lyme disease are rare, with the presenting finding include the foci of the periventricular subcortical T2 hyperintensity, nerve root enhancement with meningeal enhancement. This is the what we say. This is the unconfluent subcortical high signal with the callosal involvement. This is the callosal and callosal interface, white matter, which is similar to that of the multiple sclerosis, but this is involvement of, there's no periventricular involvement like the multiple sclerosis. This is the summary what we say in the infectious cause of the CNS differential diagnosis of the multiple sclerosis. All the infections are present in this table as a summary for the other group of differential diagnosis is toxic and metabolic demyelination, which includes central pontine myelinolysis, posterior reversible encephalopathy syndrome, Marshava benign Beguanine disease, wrinkle encephalopathy, Korsakoff syndrome, and B12 deficiency. The first, central pontine myelinolysis. Demyelination of the central pontines occur. Patients tend to be extremely ill and often have a very poor prognosis. Note that there is no inflammatory reaction associated with the osmotic demyelination. Differentiating the process differs from the multiple sclerosis, which is characterized by the marked periventricular inflammation, MR, characteristic demonstrating abnormal high signal on T2 corresponding to the region of the central pontine demyelination. In addition, extra pontine site of involvement have been described on this condition, including the white matter, cerebellum, thalamus, colobus pallidus, putamen, lateral geniculate body, giving rise of the term extra pontine myelinolysis. This is pontine myelinolysis. Usually the myelinolysis appeared first before the appearance of the lesion in the T1 and T2. In the diffusion weight, it will be more easily picked. This is diffusion weighted with pontine demyelination, which is not clearly seen in the T1. And this is an example for the extra pontine demyelination, which is seen in the basal ganglia. Posterior reversible encephalopathy syndrome. It is known as an acute hypertensive encephalopathy or reversible posterior leukoencephalopathy. It is a neurotoxic state that occurs secondary to the inability of the posterior circulation to regulate or respond to acute change in the blood pressure. Hyperperfusion would result in disruption of the blood-brain barrier, resulting in the vasogenic edema, usually without infarction, most commonly in the parieto-occipital region. Vasogenic edema within the occipital and parietal region accounting for 95%, usually symmetrical watershed area, including within the frontal, inferior temporal, cerebral, and brainstem region may also involve. Both cortical and subcortical locations are affected. There are three main imaging patterns: hollow hemispheric at the watershed area with the superior frontal sulcus and the parieto-occipital dominant. This is parieto-occipital area with area of the, sometimes there will be small hemorrhagic foci, which is seen in the CV, and in later follow-up, there will be a complete resolution of the state. Marshall-Fabian disease. It is a rare CNS disorder usually seen in the context of the alcoholism and malnutrition involving the central fiber, corpus callosum, and with necrosis and demyelination. Other white matter tract may be involved, including the anterior and posterior commissure, centrum semi-ovale, and the middle cerebral peduncle. MRI, corpus callosum may be appear edematous and acute phase and atrophic in the chronic state. In T1 should be hypointense in the corpus callosum in the acute phase, and in hyperintensity of the corpus callosum in the acute phase was sitting in the 8th diagnosis, while in the subacute may show hypointense focal area, which is representing the hemosiderin deposition. MR spectroscopy show the NAA creatinine ratio may show progressively decrease to the minimal level after the first few months, followed by the partial recovery after the around 11 months. This is the symmetrical hyperintense in the splenium. This is diffusion. This is T2 axial, which is seen the hyper signal intensity in the splenium. Also, in the there may be in the genu and the corpus callosum may be seen. This is the high signality in the corpus callosum. Again, another differential diagnosis in ring-wearing encephalopathy and Korsakoff syndrome, which is also is a form of the thiamine vitamin B1 deficiency, which is typical seen in the alcoholism. The acute clinical presentation usually will be acute confusion, ataxia, ophthalmoplegia. On MRI, T2 generally symmetrical increased signal intensity in the mammillary body, dorso, medial thalami, tectal plate, periaqueductal gray matter around the third ventricle, and contrast enhancement. Most of the contrast enhancement most commonly are in the mammillary body. Enhancement will be in the mammillary body. The restricted diffusion can be seen in the same region in spectroscopy with the normal NIA and notable present of not present in the lactate. This is what we say. It is hyperintensity signal on the tectal plate. It is the tectal plate, which is a contrast enhancement, especially in the brain, which is enhanced. This small, it is enhanced MRI, which is seen the enhancement of the lesion in the mammillary body, and the both thalami also seen. Another differential diagnosis: radiation leukoencephalopathy. It is radiation leukoencephalopathy followed by the cumulative dose of the exceed the 40 gyri delivered to the brain and occur in the 6 to 9 months after the treatment. This is radiation encephalopathy. This finding consists with abnormal high signal T2, typically involving the confluence of the area of the white matter, extending involving the subcortical white matter in the distribution of the radiation brain. radiation necrosis and radiation arthritis is also another differential. The major hazards are related to the CNS radiation. These are the major hazards in the CNS radiation. Both of the radiation affecting are strongly dose related and are less commonly seen today because of the greater fractionation of the CNS radiation dose. Radiation necrosis may occur several weeks to several years after the radiation. Most commonly occur between the 6 to 24 months after the radiation. Radiation necrosis is rarely noted at less than 6 months after the treatment, unless the gamma knife is employed, can be progressive and fatal, and present as an enhancement lesion or with a mass effect of the ring enhancement or the multifoci of the enhancement, mimicking the recurring neoplasm. Radiation may also be induced telangiectasia. This is radiation necrosis, and which is seen in the hyper-enhancement, auricular enhancement lesion in the area of the radiated part. This is the
الهستري هنا الهستري يحكم بس الصورة احكي عليها بابا بس الصور.
نعم.
لا تقرأ التكست.
This is a hyper enhancing lesion, the area of the radiation, an area of radiation which is spectroscopy show the choline and acetyl with the major metabolic destruction could be the normal area with the radiation necrosis could be different, could be differentiated. Another one, demyelinated disease. Demyelinated disorders are a subset of the white matter disorder characterized by the abnormal myelination, which include numerous inherited conditions that are characterized by the affected structure and functional of the myelinated sheath. This is a metachromic leukodystrophy, which is the most common hereditary leukodystrophy and one of the lysosomal storage disease. It has characteristic image feature including periatrial and to the lesser extent frontal horn leukodystrophy, as well as the periventricular perivenular sparing result in the trigode pattern on the fluid sensitive MRI sequence. It's characterized by the bilateral symmetrical confluent area of the periventricular deep white matter signal chain, particularly around the atria and the frontal horn, with sparing of the subcortical U fiber, leading to the butterfly pattern. Progression can lead to cortical and subcortical atrophy. Signals are characteristic. T1 affected area will be low signal, and T1 gadolinium, no enhancement is characteristic. In T2 affected area will be high signal with a trigode pattern or axial in the leopard pattern of the region. Spectroscopy reduce in spectroscopy reduce N-acetyl aspartate will increase myoinstall and increase lactate. This is what we say. This is the leukodystrophy, mitochondrial leukodystrophy, which is seen in the post-occipital hyper-intense periventricular hypersignal intensity with increase in reduce in the creatinine and increase in NAA and the choline as in spectroscopy, which appear as trigode appearance. This is like a trigode appearance. Adrenal leukodystrophy, inherited metabolic paroxysmal disorder, and one of the more common leukodystrophic in the both children and adults. It's characterized by the lack of the oxidation of a very long chain fatty acid, the result of the severe inflammatory and demyelination typical of the periventricular deep white matter with posterior predominance pattern and early involvement of the splenium, corpus callosum, and parietal white matter change. Most patients will demonstrate characteristic MRI finding. Age of onset is 5 to 10 years. This is axial CT with flare and contrast. So the parietal occipital white matter change was extending to the splenium of the corpus callosum. And there will be in CT appear in the hypointense edema around the periventricular lesion. This is the hypointense area with the high signal intensity in the flare was splenial involvement in the contrast enhancing T1. Lyme disease, it is subacute necrotizing encephalopathy. It's a mitochondrial enzyme defect, which is commonly manifested in the infant or children usually younger than the 5 years. This is MR abnormality.
بس عددين ابني مو هذا مو الايج مال الامس يعني كلها مال انفانت وتشايلد هود يعني فبس عددهن وذاك الصوره بس اشرح اقول هاي اللي ديزيز.
نعم
هذا لك انت
مو كثير هوايه دكتور 10 سلايدات ممكن.
احنا هذا يعني الليكوديستروفي واللي ديزيز والهذه ما نقدر ندخلها ويا الديفرنشال دايجنوسيس مال الام اس. الام اس الايج برزنتيشن يختلف عن هذول كله below 10 years يجون. يلا.
نعم. This is the periaqueductal gray matter. That's typical with basal ganglia, which is typical for the Lyme disease. Adrenal and Canavan disease, also it's a different, one of the differential diagnoses. This is the high signal, high intensity in the basal ganglia. This is the progressive quadri. Affecting U fibers and will enzyme diagnose the deficiency of the enzyme of the aspartase, and in the Canavan disease with neoplastic condition. This is the last one, which is the glioma, lymphoma, and metastasis. And I have the mentioned in the first in the diagnosis of the multiple sclerosis. That's all. This is the reference. And thank you.